Thrombophilic complication in obstetrics. Pregnancy, childbirth, and the puerperium pose serious challenges to a woman's hemostatic systems. Implantation, placentation, and uterine spiral artery remodeling lead to the development of high volume, high flow, low resistant uteroplacental circulation required for human fetal development. They require unchanged hemostatic responsiveness to avoid potential fetal hemorrhage. The price paid for this essential hemostatic adaptation to human hemorrhageal placentation is an increased risk of superficial and deep venous thrombosis and pulmonary embolus, acquired or inherited thrombophilias, obesity, advanced maternal age, advanced parity, antepartum hospitalizations, surgeries, and infections are major risk factors for venous thrombosis and pulmonary embolus in pregnancy and in a puerperium period. Indeed, a recent study from the United Kingdom of nearly 1 million reproductive age women, the risk of venous thrombosis for those during the third trimester and the first 6 weeks postpartum were calculated to be 6 and 22 times higher, respectively, than for non-pregnant women. The incidence of all thromboembolic events averages approximately 1 per 1,000 pregnancies, and about an equal number are identified antepartum and in the puerperium. Thromboembolic disorders, it can be venous thromboembolism. Frequency during the puerperium has decreased remarkably as early ambulation has become more widely practiced. Even so, thromboembolism rate has increased significantly during the past 2 decades. Also, this increase may reflect the higher sensitivities of newer diagnostic modalities, and pulmonary embolism still remains a leading cause of maternal deaths in the United States. Pregnancy is a state characterized by the vitro triad. This triad includes hypercoagulability, venous stasis, and endothelial injury, in turn promoting thrombosis. Pregnancy is a state of hypercoagulability due to alterations of coagulation proteins. Factor 1, 2, 7, 8, 9, and 10 increase in pregnancy. Resistance to the anticoagulant protein C is increased, and protein S level, a cofactor to protein C, decrease. Plasminogen activator inhibitor type 1, you can see in the picture like PAI1 level increase 5-fold, which reduces fibrinolytic activity. Thrombophilic disorders can exacerbate the effects of these changes in coagulation proteins, can increase the procoagulant effect, or can decrease the effect of anticoagulants, thus increasing the patient risk for venous thrombosis. In pregnancy, venous stasis also increases as the lower extremity veins dilate, followed by venous compression by gravid uterus and enlarging iliac arteries. Situation of decreased mobility, maybe surgery, cesarean delivery, bed rest, prolonged travel, or air travel may exacerbate stasis. Endothelial injury may occur antepartum or at the puerperium period, or at the delivery. The combinations of these factors culminate to increased risk of venous thromboembolism in pregnant and postpartum patients. Risk factors for thromboembolic complications. Pregnancy-related risk factors: increased maternal age, cesarean section, especially emergency sections, thrombophilia, a family or personal history of thrombosis, and obesity. The puerperium itself is a risk factor for the most probably trigger for that is delivery itself, because vessel trauma can cause thrombosis and synthetic coagulation activation in the mother's circulation can easily occur. Immobilization after delivery can substantially add to this risk. An individual assessment of the thrombotic risk should be undertaken ideally before or in early pregnancy. There is an increased risk of thrombosis in pregnant patients with thrombophilia depending on severity of thrombophilia. Thrombophilia, actually, it's a condition in which there is an imbalance in naturally occurring blood clotting proteins or clotting factors. Several important regulatory proteins can act as inhibitors in the coagulation cascade. Normal values for many of these proteins during pregnancy are found in appendix. Inherited or acquired deficiencies of these inhibitory proteins are collectively referred to thrombophilias. This can lead to hypercoagulability and recurrent venous thromboembolism. Also, these disorders are collectively present in about 50% of white European population. They are responsible for approximately 50% of all thromboembolic events during pregnancy. Thromboembolism types, it's maybe inherited thrombophilias, acquired thrombophilias, and mixed thrombophilias. Inherited thrombophilias. Patients with inherited thrombophilic disorders often have a family history of thrombosis. Inherited thrombophilias are also found in up to half of all patients who present with venous thromboembolism before the age of 45 years. Thromboembolism occurs in the absence of risk factors such as surgery or immobilization. Inherited thrombophilias, it's a rare thrombophilic mutation such as gen polymorphism of plasmaminogen activator inhibitor 1, factor 13, or a polypoprotein B do not generally transfer an independent risk for thrombosis. You can see here inherited thrombophilias, and they are associated with venous thromboembolism. So inherited thrombophilias has following types. It can be factor V laden heterozygote, factor 5 laden homozygote thrombophily, gen heterozygote, thrombophilin gen homozygote, factor V laden prothrombin double heterozygote, antithrombin 3 activity, protein C and protein S antigen activity. Inherited thrombophilias are a group of genetic predisposition of venous thrombosis embolias. Different thrombophilias are associated with different risks for venous thrombosis embolia, and they can be classified as low risk or high risk based on the relative increased risk of venous thrombosis embolias associated with specific thrombophilia. Low-risk inherited thrombophilias include the following: heterozygote factor 5 laden or factor B laden heterozygote prothrombin G2021A mutation, protein S and protein C deficiency. And the high-risk inherited thrombophilies include the following. You can see them in the slide. Factor V latent mutation is the most prevalent of the known thrombophilia syndromes. Because of this mutation, factor V gains resistance to degradation by activated protein C. The unimpeded abnormal factor V protein retains its procoagulant activity and predisposes to thrombosis. Heterozygous factor V latent inheritance for factor V latent is the most common heritable thrombophilia. Women who are heterozygous for factor V latent account for approximately 40% of venous thromboembolism cases during pregnancy. Pregnant women who are homozygotes without a personal or family history have 1 to 4% risk for venous thromboembolism, where those with such a history have an approximately 17% risk. For diagnosis during pregnancy is performed by DNA analysis for the mutant factor V gen. Prothrombin G2021O mutation. Mutation in the prothrombin gen leads to excessive accumulation of prothrombin, which then may be converted to thrombin. For a heterozygous carrier with a family history, risk of venous thromboembolism during pregnancy exceeds 10%. Without such a history, risk of venous thromboembolism during pregnancy is less than 1%. Homozygous patients or those who inherit a G2021OA mutation with a factor V latent mutation have an even greater thromboembolism risk. Protein C deficiency. Actually, protein C is a vitamin K dependent anticoagulant protein that degrades factor V and factor VIII. Over 160 mutations that cause protein C deficiency have been reported. It is inherited in autosomal dominant fashion. Also, the risk of venous thromboembolism for different mutations may vary widely. Homozygote protein C deficiency, like homozygote protein S deficiency, cause neonatal purpura, and it's typically diagnosed shortly after birth. Protein C mutations are found in 1.2 to 1.3% of the population and convey at 6 to 12-fold increased risk for a first episode of venous thrombosis in pregnancy. In patients with no history of venous thrombosis, the overall risk of pregnancy-related venous thrombosis embolism is low. Patients with a personal or family history of venous thromboembolies have a 2 to 7% risk of thromboembolies during pregnancies. Homocystinemia. Hyperhomocysteinemia is the most common cause of elevated homocysteine in the C667T terminable mutation of the enzymes 5,10-methylene tetrahydrofolate reductase. Inheritance is autosomal recessive. Elevated homocysteine levels may also result from deficiency of one of several enzymes involved in methionine metabolism and from correctable nutritional deficiency of folic acid, vitamin B6, or vitamin B12. During normal pregnancy, mean homocysteine plus concentration are decreased. Thus, to make a diagnosis during pregnancy recommends a fasting threshold of more than 12 millimole per liter to define hyperhomocystinemia. Elevated level is a weak risk factor for venous thromboembolism in pregnancy. Another high-risk inherited thrombophilia type is antithrombin deficiency. Antithrombin synthesized in the liver. Antithrombin is one of the most important inhibitors of thrombin in clot formation. Antithrombin functions as a natural anticoagulant by binding and inactivating thrombin and the activated coagulation factors 9A, 10A, 11A, and 12A. Antithrombin deficiency may result from 100 different mutations that are almost autosomal dominant. There's two types of antithrombin deficiency. Type 1 deficiency is the result of reduced synthesis of biologically normal antithrombin, and type 2 deficiency is characterized by normal levels of antithrombin with reduced functional activity. Thrombin deficiency may result from hundreds of different mutations that are almost always autosomal dominant. Homozygote antithrombin deficiency is lethal. Actually, it's a rare form and it affects approximately 1 in 2,000 to 500 individuals, and it is the most thrombogenic of heritable coagulopathies. The thrombosis risk during pregnancy among antithrombin deficient women without a personal or family history is 3 to 7%, and it is 11 to 40% with such a history. Especially those affected have approximately 50% lifetime risk of venous thromboembolism. Given such risk, affected women are treated during pregnancy with heparin, regardless of whether they have had a prior thrombosis. When anticoagulation is necessary, with health such as during surgery or delivery, found that treatment with recombinant human antithrombin protected against venous thromboembolism development in 21 patients with hereditary antithrombin deficiency. Sharp and Associates describes successful use of antithrombin concentrate infusions plus therapeutic anticoagulation in pregnant women with antithrombin deficiency who develop a thrombosis during the third trimester, despite therapeutic doses of low molecular weight heparin. So you can see here how inherited thrombophilias affect the coagulation system. So mutation in G2021OA increased prothrombin levels. It causes thrombin and coagulation. Antithrombin deficiency decreased thrombin neutralization. It causes thrombin and coagulation, or thrombin binds to thrombomodulin on endothelial cells, and it can bring to hyperhomocytopenia. Also, factor-related mutation, factor 5 laden mutation, factor 5 resistant to degradation for protein C. So it can inactivate factor 5A and inactivate factor 8A, and it will controls thrombin generation, and it causes thrombin and brings to coagulation. And here you can see a relationship between inherited thrombophilias and pregnancy complications other than thrombosis. So it was found that no increased risk for early onset or severe preeclampsia with women with factor 5 laden mutation, prothrombin G2021OA mutation, or hyperhomocythemia. Women who carried the prothrombin gain mutation had a 3.6-fold increased risk of adverse pregnancy outcome, including severe preeclampsia, fetal growth restriction, placental abruption, or stillbirth. The inherited thrombophilias are a heterogeneous group of genetic disorders associated with arterial and venous thrombosis, as well as fetal loss. The occurrence of thromboembolic event is highly dependent on other predisposing factors such as pregnancy, immobility, obesity, surgery, infection, trauma, and the presence of other thrombophilias. However, the most important risk is a personal or family history of venous thrombosis. It presents that privileged and high-risk venous thrombosis among pregnant patients with and without a personal or family history of venous thrombosis. So, how I told before, thrombophilies are divided into high and low risk based on the overall risk of a venous thromboembolism. And all patients who present with venous thromboembolism in pregnancy or postpartum should be considered for an appropriate workup for inherited thrombophilias. Non-thrombotic pregnancy complication and thrombophilias. So maternal thrombophilias are not associated with pregnancy loss prior to 8 to 10 weeks of gestation, explained by the embryogenetic development of vascular system. Before 8 weeks of gestation in the embryo, there is only yolk sac vascularate, and thereafter a contact between the maternal and fetal circulation develops. Therefore, it seems unlikely that maternal thrombophilia can impair embryonic development at the earliest gestational stage. Women with thrombophilia show an increased risk for pregnancy loss at the end of the first and in the second trimester. Those with FPL or prothrombin gene variants show a higher risk of late pregnancy loss. Recurrent pregnancy loss has been linked to inherited thrombophilia, particularly with protein C and S deficiency, FPL, and prothrombin gene variant. A significant association with increased risk for placental abruption was only observed with heterozygote FVL and prothrombin gene variant, intrauterine growth retardation, and also thrombophilias can cause non-thrombotic pregnancy complications. Risk assessment for venous thrombosis, thromboembolias. Major risk factors for venous thromboembolism in pregnancy and in postpartum period: previous cesarean sections, obesity, prolonged bed rest, immobility, preeclampsia, nephrotic syndrome, current infection, and recent surgery, previous venous thromboembolias, and thrombophilia. In women with high risk dose of low molecular weight heparin, prophylaxis should be continued for 4 and 6 weeks of postpartum period. Management for venous thromboembolias. First of all, it's anticoagulant therapy. The choice of anticoagulant depends on maternal or fetal complications. Unfractioned heparin and low molecular heparin do not cross placenta and they are safe for fetus. Maternal bleeding complications appear to be uncommon with a low molecular heparin. Prevention of venous thromboembolias is a low dose of molecular weight heparin is a prophylaxis of choice in pregnancy at risk for venous thromboembolias. Actually, no one laboratory monitoring is required, and all women with previous venous thromboembolias or thrombophilias should be additionally encouraged to wear elastic compression stockings throughout their pregnancy and for 6 to 12 weeks after delivery. Acquired thrombophilias, the form of acquired thrombophilias is an antiphospholipid syndrome. Antiphospholipid syndrome is autoimmune disorder which manifests clinically as recurrent arterial or venous thrombosis and fetal loss. Characteristic lab abnormality exists as antibodies directed against membrane anionic phospholipids or their associated plasma proteins. Antiphospholipid syndrome is also known like Hughes syndrome, named after Graham Hughes. Another name may be Hughes syndrome as antiphospholipid syndrome or lupus anticoagulant syndrome. Antiphospholipid syndrome has three types. Primary antiphospholipid syndrome occurs in the absence of any other related disease. Secondary phospholipid syndrome occurring in the context of the other immune diseases such as systemic lupus erythematosus and catastrophic antiphospholipid syndrome. Its rare cases leads to rapid organ failure due to generalized thrombosis. This is termed and is associated with high risk of death. The antiphospholipid syndrome, the pathogenesis of APS involves a cofactor beta-2 glycoprotein. In antiphospholipid syndrome associated fetal loss, there is typically massive infarction and thrombosis of the placental and decidual vessels, probably secondary to spinal arteriovasculopathy. Platelet deposition and prostanoid imbalance may be implicated in similar way to preeclampsia. Many of the adverse outcomes described are the end result of defective abnormal presentation, and these findings support placental failure being the mechanism by which antiphospholipid antibodies are associated with fetal with late loss, but antiphospholipid antibodies associate thrombosis with the placenta cannot explain all the recognized pregnancy complications in phospholipid syndrome. Antiphospholipid antibodies bind the human trophoblast in vitro. Trophoblast cell membranes behave as target for both beta-2 glucoprotein 1 dependent and beta-2 glucoprotein 1 independent phospholipid antibodies. And antiphospholipid antibodies reduce gonadotropin release and inhibit trophoblast invasiveness. For clinical criteria to diagnose antiphospholipid syndrome, it's vascular thrombosis. They may be arterial, venous, or small vessel thrombosis. Arterial thrombosis is cerebrovascular, most common. Coronary occlusion and arterial thrombosis in a typical site may also occur, such as subclavian or bronchial. Venous thrombosis and the small vessel thrombosis, almost 2/3 of the events are venous thrombosis. Up to 50% venous thrombosis are pulmonary emboli. Thrombosis is usual location also common, such as portal or splenic or cerebral veins. And for diagnosis, one of the main criteria is pregnancy morbidity. Women need to have at least one unexplained fetal death or beyond 10 weeks, at least one preterm birth before 34 weeks because of eclampsia, severe preeclampsia, or placental insufficiency, or at least 3 unexplained consecutive spontaneous abortions before 10 weeks. Other recognized features are thrombocytopenia, hemolytic anemia, livedo reticularis, and cerebral involvement. Also, heart valve disease, hypertension, pulmonary hypertension legs are features for antiphospholipid syndrome. For diagnosis, laboratory criteria, the 3 best standardized assays are lupus anticoagulant. Lupus anticoagulant is a misnomer coined because it prolongs coagulation time in vitro. It is detected by prolongation of the activated partial thromboplastin time or the dilute Russell-Viper venom time. This prolongation fails to correct with the addition of platent poor plasma, but corrects with excess phospholipids. Another criteria is anticardiolipin antibodies levels, high levels, and anti-beta-2 glucoprotein 1 antibodies levels, high level, are most strongly associated with phospholipid antibody syndrome. And it is important to remember that up to 25% of thrombotic events in women with antiphospholipid syndrome occur during pregnancy or in the puerperium. How its effect on pregnancy? So first of all, the risk of thrombosis is exacerbated by the hypercoagulable pregnant state. Pre-existing thrombocytopenia may worsen during pregnancy. Also, the risks of miscarriages, second and third trimester of fetal death, preeclampsia, intrauterine growth retardation, and placental abruption are increased. Establishing causality for first trimester losses is difficult since the risk of miscarriages is high in the normal population, and APL are more common in women suffering 3 or more first trimester miscarriages than in those with 1 or 2 miscarriages. Also, fetal death in antiphospholipid syndrome is typically preceded by intrauterine growth retardations and oligohydroamnions. The risk of fetal loss is directly related to antibody titer, particularly the G or ACL form. Also, many women with a history of recurrent loss have only immunoglobulin M antibodies. And the risk is difficult, and the presence of antiphospholipid antibodies does not preclude successful pregnancy. And previous obstetric history is the best predictor of pregnancy outcome in the woman with antiphospholipid syndrome. Preeclampsia is a common and often severe and of early onset in the later group. APS treatment, first of all, lifestyle modification. Effective way of activating this include no smoking, eating healthy food with low fats and low sugar, it's regular exercise, maintain a healthy weight and losing weight if you're obese. When it comes to management, in pregnancy, women with a history of thrombosis, recurrent miscarriage, intrauterine fetal death, or severe early onset preeclampsia or intrauterine growth retardation should be screened for presence of lupus anticoagulants or anticardiolipin antibodies. A detailed history of the circumstances of the fetal loss is essential to exclude other causes of late miscarriage, such as cervical incompetence or idiopathic premature labor, the presence of APL does not constitute a diagnosis of antiphospholipid syndrome unless the clinical features are suggestive. So in antenatal care of pregnant women with antiphospholipid syndrome should be multidisciplinary and in centers with expertise of caring for these high-risk pregnancies. Aspirin inhibits thromboxane and may reduce the risk of vascular thrombosis. There are many non-randomized studies suggesting that low-dose aspirin is effective and it can prevent pregnancy loss in experimental APC mice. Aspirin is a logical treatment in those with APLs but no clinical features of antiphospholipid syndrome. Randomized controlled trials of aspirin as a single agent in antiphospholipid syndrome pregnancy do not support any benefit over placebo. However, such studies have been undertaken in low-risk women. Most centers now advocate treatment with low-dose aspirin for all women with antiphospholipid syndrome prior to conception in the belief that the placental damage occurs early in gestation and that aspirin may prevent failure of placentation. Women with antiphospholipid syndrome and previous thromboembolism are at extremely high risk of further thromboembolism in pregnancy and the puerperium and should receive antenatal prophylaxis with a high prophylactic dose of low molecular weight heparin. Many of these women are on lifelong anticoagulant therapy with warfarin. The change from warfarin to heparin should be active prior to 6 weeks gestation to avoid warfarin embryopathy. A few women with cerebral arterial thrombosis due to antiphospholipid syndrome on long-term warfarin may experience transient ischiemic syndrome when low-dose molecular weight heparin is a substitute for warfarin. If these do not improve on higher doses of low molecular weight heparin, the reintroduction of warfarin is justified to prevent maternal stroke. For management recommendation for antiphospholipid antibodies pregnancies, if there's no antiphospholipid antibodies, if there's antiphospholipid antibodies but no thrombosis or pregnancy loss, so 75 milligram aspirin only is recommended. If a woman had previous thrombosis in her history, so anti-aspirin and low molecular weight heparin is recommended. If she had antiphospholipid antibodies and history of previous pregnancy complication, so here also aspirin and low dose molecular heparin is recommended. Women on long-term warfarin treatment may recommend cis postpartum, and low molecular weight heparin is discontinued when the international normalized ratio is more than 2. Women with previous thrombosis should receive postpartum heparin or warfarin for 6 weeks. And women without previous thrombosis should receive postpartum heparin for at least 5 days to 6 weeks, depending on presence of other risk factors. Women receiving azotherapeutic or prophylactic anticoagulation should be converted from low molecular weight heparin to the shorter half-life and fraction heparin in the last month of pregnancy or sooner if delivery appears. The purpose of this conversion to UFH has less to do with any risk of maternal bleeding at the time of delivery, but rather with a neurexal blockade complicated by an epidural or spinal hematoma. And it's recommended for women scheduled for a planned delivery who are receiving twice daily adjusted dose subcutaneous UVH or low molecular weight heparin. Discontinue their heparin 24 hours before labor, induction, or cesarean delivery. Patients receive once daily low molecular weight heparin should take only 50% of their normal dose on the morning of the day before delivery. If labor begins while taking UVH, clearance can be verified by an APT. For women in whom anticoagulation therapy has temporarily been discontinued, pneumatic compression devices are recommended. So, antiphospholipid syndrome has been associated with both venous and arterial vascular events. A meta-analysis of 18 studies has shown elevated risk of venous and recurrent venous thromboembolias among patients with systemic lupus erythematosus who tested positive for antiphospholipid syndrome. Overall, when compared with those SLE patients who do not test positive for either test, those with lupus anticoagulants and anticardiolipin antibodies have a respective 6-fold and 2-fold increased risk of venous thrombosis. These antibodies also pose a risk to patients without SLE, systemic lupus erythematosus. The lifetime prevalence of arterial or venous thrombosis in affected non-systemic lupus erythematosus patients is approximately 30%, with an event rate of 1% per year. The risk of thromboembolic events are highly dependent on the presence of other predisposing factors that include pregnancy, estrogen exposure, immobility, surgery, and infections. Antiphospholipid syndrome, as mentioned above, has also been associated with adverse pregnancy outcome and accounts for 14% of venous thromboembolias in pregnancy. In fact, the risk of thrombotic event in pregnancy is 5% with prophylaxis. All patients who present with venous thromboemboly in pregnancy or in the postpartum period should have an appropriate antiphospholipids workup. So, major factor for diagnosis is one of two clinical criteria: thrombosis or pregnancy morbidity, and one of three laboratory criteria. And for treatment for antiphospholipid syndrome and for all venous thromboembolias, is low-dose aspirin and heparin has to be starting with positive test till 34 weeks of gestation.